We're going to talk about sepsis drops and compliance stuff. We know that sometimes it's confusing to understand CMS versus the national guidelines versus whatever we're required to do. So we're going to go over that. I think my biggest disclosure, I am full-time with Baxter as a medical science liaison, and I'm on the Sepsis Alliance Advisory Board. All right. So we're going to compare and contrast the national guidelines to the SEP1 bundle to hopefully help you guys understand that a little bit better. And then we're going to talk about the importance of individualized care for our patients. And actually, CMS is allowing us to do that even more today than they did last year. All right. So what is CMS? Centers for Medicare and Medicaid Services. I know you guys are probably all aware of what that is, but basically they help compensate, right? They make sure they compensate the hospital as long as we're doing what we're supposed to be doing, right? So there can be some incentivizing and there can be also some penalizing. All right. So it's important that we make sure we practice to standards, and that's what they're trying to do, to initiate standards. And they've added sepsis as one of the standards. Okay. So we call these, a lot of the things over the years have been called 4 measures. All right. When we talk about SEP1, it's important to understand, what does SEP1 mean? Well, SEP1 is shorthand for the severe sepsis and the septic shock management bundle. Okay, that's what CMS requires us to do. There's basically, we call it also the 3-hour and 6-hour bundle, and we'll go over that in just a moment. But it lays out guidelines for the hospitals on how we can fight against sepsis, how we can best identify our patients, as well as focusing on early recognition. Okay, early recognition and also life-saving therapies. Now, as far as brand new, fairly brand new, since January, we are in what's called the performance period for this value-based purchasing. So this is what's new. There's domains that they require us to do well in, right? And the domain that's lilac in color, it's called the safety domain. And they have added severe sepsis and septic shock. And so basically what they're doing is they've looked at a baseline period in 2022. How did your hospital do with sepsis compliance? And now they're looking right now, 2024. If you do better today, they'll take your today's data. If you did better in 2022, they'll take that data. But let me tell you, whatever you do well on, then you have to continually do better, or you can be penalized, right? Now, here's the deal. Your achievement threshold is 59%. So if you guys don't know what your percentage of compliance is at your hospital, I encourage you to go back and ask someone, what is our percentage of compliance? And by the way, it is in a database out there where people can look at your hospital to see how well you do. It's a little bit behind on the timing, but it does have it out there. And look, there's a benchmark of 84 percentile. I've been working with sepsis for many, many years, and we're nowhere near 84 percentile, but some places out there are. So just know that this is a big deal. It could penalize or it could help incentivize based on how well you do. So, and in my mind, it's really not about the incentivizing and penalizing. It's about taking care of our patients, right? So you want to feel confident that the things they are encouraging you to do are best practice. So we're going to kind of talk through that. All right. So CMS has what's called the 3-hour bundle. Measuring lactate, getting blood cultures before we give antibiotics, giving fluid if they meet shock criteria, and then also administering fluid if they meet shock criteria and giving antibiotics. I think I maybe said one of those twice, but we all know that, right? That's anybody here working the ED? Okay, so maybe a few hands. So yes, you know that's what you have to do quickly and in that first 3 hours. Personally, I think most of those should all be started in the first hour, and that's the way you've educated it at the hospital I'm still affiliated with. But they give you some time to get it done, okay? Now, there's also what's called the 6-hour bundle, or what has to be completed within 6 hours. So making sure vasopressors are applied by that time if the patient is still hypotensive after fluid. Want them to keep that mean arterial pressure at least greater than or equal to 65. And then if you have persistent hypotension with that MAP less than 65, or if you have that lactate that's greater than or equal to 4, you have to do a reassessment volume status. Now, and the other thing we have to do is reassess lactate if lactate is greater than 2. All right, here's the deal about this bundle. All these bundles together, the 2 of them together, it's an all or nothing bundle. You can do everything right and then forget to reevaluate the lactate that was 2.1 and it falls out. Very hard to get high numbers unless you have really good processes in place. All right, so it's a challenge. Now, there are what's called international guidelines. These are updated every 4 years. It's due to be updated next year. Super excited to see what they have to say. And these are international guidelines. A lot of what SEP 1 is requiring us to do has to do with the guidelines, but there are just some different timelines in there, and we'll kind of go through those. All right. So what does the Surviving Sepsis campaign have to do with this or say about this? Basically, this is what the guidelines suggest, called the Hour 1 bundle, okay? So the only thing that's really different is they encourage us to apply vasopressors if the patient is hypotensive to make sure we don't have a mean arterial pressure that's less than 65, okay? So basically, I think we probably do this even with the SEP 1 requirements. We're not going to wait 6 hours, right? We're going to, if our patient's low pressures, we're going to give them that. All right. So let's kind of discuss what are some of the differences between the two. Well, when we think about the definitions, first and foremost, in 2016, they took out the severe sepsis category. That makes it really hard because CMS requires us to look at severe sepsis patients. So sometimes this can be a challenge with reimbursement to our hospitals, with the insurance companies. But just know that technically by the national guidelines, there's just sepsis and septic shock. But I don't know about you, but in my hospital, we go with the SEP 1 definitions because it's too confusing to try to, because we have to monitor the severe sepsis patients too, right? So I'm going to kind of go over those definitions with you really quickly. If we don't obliterate sepsis, then it could develop into severe sepsis or septic shock. So we want to stop it as soon as we can. Now, there's really not a particular definition by CMS because we really focus on severe sepsis and septic shock with CMS. But just know sepsis is known or suspected infection plus 2 or more SIRS criteria. Okay? Then we're going to move on to, I'm going to kind of talk quickly here. SIRS. We know that SIRS is a challenge, right? It's not specific. And I will go back here just. It's not specific. It's not always related to the infection, but it's what we have. So, a lot of people say, well, everybody's going to screen positive for sepsis. And I say, no, they're not, because you have to go back and ask the question, do we have a known or suspected infection? And if they don't have a known or suspected infection, then I said, maybe their SIRS are related to something else. So in my mind, that's always what I did. Just like when people come to you with a high lactic acid, they must be septic. Well, hold on. Do they have a known or suspected infection? And they say, well, no, they've got like liver failure or they had CPR for 10 hours. I'm like, okay, right? So not everybody who has a high lactic acid or sepsis, it's really important, though, that you know these definitions so you can kind of clarify that in your mind. All right. So severe sepsis is known or suspected infection, 2 or more SIRS criteria, and organ dysfunction. When we talk about organ dysfunction, it can be very subtle, right? If your patient's just not quite meditating like they normally do, family may say, they're just not quite acting right. Neuro's down, right? Or you get a bilirubin that's 2.1. You're like, that's a little elevated. Or you get a lactate that's even greater than 2.1. All of these are organs, right? So you may have a patient with 5 organs down and they're still talking to you, right? So it can be subtle. So make sure you're looking at organ dysfunction so you know where they're at. Then the worst is septic shock, known or suspected infection, SIRS criteria, and organ dysfunction that's either hypotension after you've tried to give them some fluid or still hypotensive, or if they have that lactate greater than or equal to 4. And here's what I'm going to tell you. Many times these patients can have a higher lactate and may not be hypotensive yet. I always say that's the call before the storm. It's still cryptic shock, right? They're still in shock. They still need the interventions, even though they're not hypotensive yet. Okay, so it's important not to forget those patients. All right, next is the initial resuscitation. So the change for that in the 2021, basically, they suggest using balanced crystalloids instead of normal saline for resuscitation. So just so you know, I'm doing another talk at 11:15. If anybody wants to hear about what solutions should we use to replenish our patients or to resuscitate our patients with sepsis, I'll be doing that talk and we'll go into great detail about what we should possibly use. All right. They recommend, though, that we give 30 ml per kg within the first 3 hours of resuscitation. Now, that's the national guideline. What does CMS say? CMS is actually giving us some of the ability to not just think one size fits all. They're actually going to allow us to have it's a little area of opportunity, right? So first of all, they say if your patient has a high BMI, as long as you document your BMI and you document your ideal body weight, then those patients can get a fluid based on ideal body weight. They also say you can give lesser fluid as long as you tell them as long as it's documented what fluid you give, right? But you also have to then say why you wouldn't give the amount of fluid. So all your processes and your items in your EMR where you document need to be very clear for for everyone, providers, and for you as nurses. The other item that's fairly new, as is July of 2023, just last year, they added a thing that said we don't have to give fluid. There's 3 reasons that you can get by with not giving fluid for the patients, okay, who have septic shock. And one is that there is documentation that the patient has an implanted ventricular assist device. The second is that the physician's APN or PA or nursing documentation that the patient or authorized patient advocated who has refused IV fluids prior to or within 6 hours following presentation of septic shock. And my favorite is the physician APN, PA, or nursing documentation indicates no crystalloid fluids were ordered because the patient was not volume or was not fluid responsive. Now, we'll talk about what is a dynamic assessment. How do you know if the patient's fluid responsive or not? Let me just tell you this, though. They give specific, it has to be invasive or non-invasive. It can be totally non-invasive. And you have to use a cardiac output, cardiac index, stroke volume, or stroke volume index measure, okay? Now, I go to a lot of places across the country, and I hear that people do passive leg raises and look at blood pressure. You can do that, but the sensitivity and specificity is not what it is. And the best sensitivity and specificity is when you're looking at stroke volume, okay? So that's why it's really important, but I'm excited to see that if you know your patient is not responding to fluid, is not fluid responsive, you don't have to give fluid to this patient. And we'll do a case study in just a few minutes to help explain that. Now, this might be a good picture take because this is what you need to have for your providers. You also need to have this information mainly for providers. Now, this is a paper document, but we put it in the EMR. It's also electronic. I just took a screenshot of the paper. And the reason why it very specifically tells the provider what they are okay with doing, but they have to document it, okay? And then here's page 2 of that progress note for the 6-hour bundle. So that may be helpful for you as well. And by the way, on that doing the fluid responsive test, I did reach out to CMS because there was a little statement that it said it would be good if something about the provider acknowledging that you did a passive leg raise. And when I reached out to them, they said they do not have to have that. As long as the nurse documents it, there is nursing power. As long as we document it, we're fine. Okay. So you can document that you did a passive leg raise, patient was not fluid responsive, and if they did not get the 30 ml per kg of fluid, you should still be fine, okay? So if anybody knows your abstractors out there, hopefully they already know this. They've got a ton to know. All right, next, though, they said with the initial resuscitation, they always recommend that we use dynamic resuscitation markers, things like a passive leg raise. I'll talk about that in a second. Target that MAV of 65, reassess hemodynamic status to guide resuscitation, and normalize that lactic acid. The other thing they mentioned, so from 2021, there was no change from that, except for they did say they suggested that we use cap refill also as an assessment criteria. So how can we do dynamic measures, and what the heck is a dynamic measure, right? So what we're doing is we're looking at a small fluid bolus going back to the heart. You can do this 2 ways. You can do this with a passive leg raise, or you can do it with a small fluid bolus, and we're determining if the heart will respond. How we know if the heart responds is that there is a 10% or greater increase in stroke volume. Before we start, you get baseline data to after we start, okay? If there is a 10% or greater response, that means that that patient can take that fluid and can help forward flow to improve perfusion, to where fluid may be a good option. If this patient does not have a 10% response, then fluid is not the answer for that patient, okay? However, you can't just determine that by looking at your patient. How many of us, I'm going to confess, when my patient has been hypotensive, calls the provider and they say, give a 500 bolus, and I just do it. How do I know if this patient is really going to respond to fluid? And by the way, studies show only 50% of hemodynamically unstable patients are even fluid responsive. You guys, that's a flip of a coin. We don't know unless we're looking at fluid responsiveness and dynamic assessments. So important, the biggest take home of this talk today. All right, how can we do it? You can give a bolus, but if you give a bolus, it's not just 999 on the pump, right? That's too slow. We want to put it on a pressure bag and push it in. We're testing that left ventricle to see if they're going to have a response or not. 250 in less than 5 minutes, 500 in less than 10 minutes, okay? Really important. Now, I personally love the passive leg raise. It's well studied. It's easy to do. It can be nurse-driven. And if you do not have a nurse-driven protocol, I want to encourage you. And I'm going to tell you, I've got providers where I'm still affiliated with and aren't always as excited about it as I am. But you know what? I can educate my nurses and encourage them that if somebody is hypotensive or is hypoperfused, they deserve a dynamic assessment, and we can at least do a passive leg raise. All right? So very easy to do. Oh, and with the passive leg raise, you start with initial data to just do baseline data, right? About 4 minutes of baseline data. And then we will lay the patient flat, make sure they don't have really tight SCDs. You can keep them on as long as they're not pumped up, unplug them or something. Make sure you put it back on them. And then take the pillows out from underneath their leg, okay? And then what we're going to do, once we have our baseline data, lay them flat, we passively lift their legs. Don't have them help you at all. We don't want to do anything to have them increase their heart rate or do anything to get an abnormal response. Okay? All right. So 2 ways of doing it. I call this the poor man's fluid bolus. The reason I like it, it's free. What in healthcare is free? They're using their own volume in their lower extremities and their abdomen to go back to the heart. If there is a problem or if they're not tolerating it, lower their legs. Increase their head. No harm, no foul. Yes, somebody asked how many mLs is that goes back to their heart. I've seen anywhere from about 300 to 500. It kind of depends on how much volume is there. So it's just a quick little bolus. It should work for you. Well studied. Okay, so we can do passive leg raise or give a small fluid bolus. And everybody knows what a fluid responsive test is. Has anybody done a passive leg raise at the bedside? Excellent. All right, the next thing is vasopressors. I'm going to go really quick over this. Basically, nothing's changed. It's Levophed is the pressor of choice. Oh, yes, one thing has changed. A big thing. They suggest us starting peripherally, right? It's okay to give peripheral vasopressors. Now, it doesn't mean you need a big old 18 gauge, right? You can have a 20 gauge. You can have a 22. You want good blood flow in the vessel, right? You don't want to where there's flexion, right? There's some guidelines out there. Make sure your hospital has a policy to make sure it can be done safely. So do it safely. Make sure you've got a good blood return. As long as you do, you should be good. All right. Now, this is just to give you an example. As I put this up here, there are so many specific, and this is just one page. Many of these requirements are pages and pages of requirements by CMS that abstractors have to know. So I'm not going to read all those. But as long as you do Levophed, you should be good. Antibiotics, they have where if you feel like this patient truly is septic, give them antibiotics quick. If you're not sure, you can have a moment of pause, not too long of a moment of pause, and then give the antibiotics. We also don't want to just empirically give MRSA coverage if they're not high risk, but if they are high risk, then give it that coverage as well. All right. And then there's very specific requirements by CMS, but due to time, I'm just going to flip through that. Now, we're about to do a case study. And before we do the case study, I want to tell you some other benefits you can get from non-invasive hemodynamic monitoring. But basically, we're focusing on, is our patient fluid responsive? But sometimes you can get even extra data than just fluid responsive data, right? And I know some people just use it for that, but I'm going to give you a few more things. So remember, it's all about perfusion. We want our patients to perfuse. Remember, blood pressure is just that. It is a pressure. We need to look at flow. Pressure does not equate to flow, right? So it's important that we are looking at cardiac output, stroke volume. So when we think about preload, I want you to think stroke volume. All right, normal stroke volume is from 60 to 100. On the count of three, I want you to tell me what normal stroke volume is. 1, 2, 3. Excellent. You want to remember that. Super easy because it's normal heart rate, right? You can remember that. And if we want to know where a patient's at or if they can tolerate fluid, think V for volume, perform a dynamic assessment. All right. The next is afterload. R for resistance. We are looking at total peripheral resistance and total peripheral resistance index. It is the surrogate for SVR. We just use a different calculation that is legit, and different calculation that doesn't include CDP, so you don't have to have CDP to know that, okay? The normal number for TPR is 800 to 1200. So on the count of three, let's say that. 1, 2, 3. 800 to 1200. Excellent. You're going to need to know those two for the case study. Okay, lower the number, the more dilated the patient is. The higher the number, the more constricted, okay? And then last is contractility. C for contractility, thinking of cardiac output, cardiac index. If this is low, there's your normal. If it's low, you're going to ask why. Does this patient need fluid? And you're going to know that if you perform a dynamic assessment, right? Or if they can tolerate fluid. And then do they need an inotrope? Okay, we're going to get right to the case study. And I'll come back to that if anybody wants to take a picture. I've got my 5-minute warning. All right. So we have a 60-year-old female who arrives to the emergency department, persistent cough and fever, states it's been over a week of symptoms. She thought she could fight the infection by rest and Tylenol. She couldn't. Hypoxic. She remained hypoxic, was intubated, and she is started on the sepsis bundle in the emergency department. You can see her profile. She's febrile. She has a low blood pressure. She has a high heart rate. She has a high white count. She has a high lactate. She's sick. Everybody got the picture? There we go. All right. So diagnosis of x-ray. We're not surprised. Diagnosis of x-ray. Diagnosis of pneumonia post x-ray. They went ahead and did a great job, did the hour 1 bundle in the emergency department, but they only gave a 1-liter bolus because they went ahead and in the emergency department connected non-invasive hemodynamic. Yes, you can do this in the emergency department, and they did that, so kudos. And so our first question after we connect them, 45 for stroke volume, is that low? Yeah. Yes. So TPR 757, is that low? Yes. So we're dilating. And our stroke volume's low. Stroke volume is that amount that's in the left ventricle that we eject with each beat, right? And you can see cardiac index and cardiac output. All right, so we do a passive leg raise because we're hypotensive or hypoperfused, right? Do a passive leg raise or do a small fluid bolus, whichever you prefer, and it's only 4.4% increase. Is my patient fluid responsive? Holler it out. Okay, so are we going to get fluid? All right, that's what I'm talking about. Now, based on our clinical findings, since we're not giving fluid, what does this patient need? We're hypotensive, we're vasodilated. What do we need? Pressor. So we're going to give a pressor. Excellent. So the pressor is started within an hour. We're institution max. That's never a good day, right? But it's real. And we notice we're still with a low stroke volume. But look, my TPR is better, isn't it? Why is my TPR higher? Squeezing, right? We added a pressor. So it's kind of nice. Don't you all like to be validated a little bit? I love it when I see validation on a monitor in a patient room. I'm like, oh, that's what I'm talking about. That's what we did that for. All right. But we still have a little bit of a problem, right? We're only a 60 map and we're still low stroke volume. So what are we going to do? A passive leg raise. Somebody screaming what the intervention is. Before we give that, whoever screamed that, we're going to do a passive leg raise first because we always want to know if they're fluid responsive. By the way, it's not just one and done. You can change from being fluid responsive to not being fluid responsive. So don't just think just because they were fluid responsive 2 hours ago that they're not going to be now. Or they are going to be now, okay? All right. So we increased. We did another passive leg raise. We're at 6.1%. Is this patient fluid responsive? Are we going to get fluid? Absolutely not. So we are going to, in this scenario, add another pressor. And the reason behind that, if you notice, your cardiac index and your cardiac output are still okay. All right. But your stroke volume is low and your blood pressure was still low. We aren't dilated because we already have one pressor. And this is based on the national guidelines. So we are going to start vasopressin on this patient. Okay. So now pressors are continued. Blood pressure did improve for about the next hour. Lactate decreased to 4, so we think we're perfusing a little bit better. After about an hour, though, cardiac index dropped and stroke volume decreased even more. But look at my map. But the map is okay. And by the way, If you didn't have this patient on a hemodynamic monitor, you would have no clue how sick this patient really is, right? Stroke volume is down to 35, and look at what my TPR is. What have we done to this patient? We clamped him down majorly. Now, we're trying to save the patient, so it's not like you're trying to be mean and making it too hard for the patient to pump against the pressure, right? But what does that do to the cardiac index and cardiac output? So is this patient hypoperfused or hypotensive? Yeah, we're hypoperfused. We're in a cardiogenic shock state, which many septic patients get into a cardiogenic shock state, right? So yes, we are still, let's do another passive leg raise, and 8.6% increase. Am I fluid responsive? Am I giving fluid? What can I give now? I mean, because I have such a low cardiac output and index, and I'm still low in stroke volume. Anybody think about inotrope? Good, excellent. Sorry, it's hard to hear here. Pressure 1, 2, and an inotrope is infusing. The patient did great for 3 hours. 3 hours later, the blood pressure dropped. We're down to 61. It's fairly subtle, but the stroke volume dropped first. And many times you'll see this drop before you'll see this, and stroke volume dropped to 42. But look at my TPR and my cardiac index. That's better, isn't it? It's a little bit better here. And we're at all three. And by the way, let me back up for a second because I didn't even show you this. This is pretty impressive. 1 hour post-albuminine, our MAP's better, our stroke volume's better, TPR normalized, right? And then the cardiac index and output came up nicely. All right, so we're still going to check again as this patient is hypotensive or hypoperfused. Yes, they are. What are we going to do? Passive leg raise. All right, and guess what? Are we fluid responsive? Are we going to get fluid? Yes. And what does that do? We give fluid, and look what it does over here. Just a second, I'll give it up here. We give another, we get fluid and pressure. The pressure is good. The TPR is good, and the cardiac index and output's good, but my stroke volume is still low. So I'm like, oh, do I really need more fluid? I don't know. A lot of people live on the bottom portion of the Frank-Starling curve, but what can it hurt to try, right? No harm, no foul. We did a passive leg raise. And the passive leg raise showed that the patient was still fluid responsive. So we gave another 500. And look, we brought up our stroke volume to the normal amount. All right. So we are going to hold tight now and hopefully start down titrating our pressors as soon as we can, right? So there are some great resources out on the web, lots of references. I know you may have some questions on the time. I do want to mention you've all been given a card. Yesterday, we launched our brand new medical website. It has a whole hemodynamic lecture on there that I've placed on there. Plus, it has sepsis lectures. It has podcasts, all kinds of fun things. We want you to check it out. Sign up. You've got a QR code. Sign up. We'll send you some good tidbits every week or so. So hopefully you'll get that. Thank you all for coming and hanging around. We're going to share with you where we'd like you guys to go and see a passive leg raise, okay?